Hello everybody, we are going to discuss about treatment of drug sensitive pulmonary tuberculosis. I am Dr. Sridhar, Professor of TB and Respiratory Medicine at Stanley Medical College and Superintendent Government Hospital of Thoracic Medicine, Tambaram Sanatorium. The goals of TB treatment are mainly to cure the patient, to prevent death and reduce morbidity by ensuring relapse-free cure, to render patient non-infectious, break the chain of transmission and to decrease the pool of infection, to minimize and prevent development of drug resistance, to restore quality of life and productivity. The evolution of TB treatment goes like this. In the 1940s, we had a single drug only available, that was streptomycin, and in the 1950s, we had the option of adding one more drug and it was a 2-drug regimen. And 1960s, we had the option of adding the injection to 2 more oral drugs, that is 3-drug regimen. And in the late 1960s, 3-drug drugs were administered for a duration of 9 months. And in the 1970s, we had the advantage of introducing the short course of 4 drugs of 6 months duration. For the TB treatment, currently recommended regimens are the results of numerous clinical trials in many parts of the world. Many of the principles of TB treatment were evolved from the research in NIRT Chennai: efficacy of domiciliary treatment, efficacy of short course chemotherapy, efficacy of intermittent treatment, and necessity of supervised treatment, otherwise known as DOTS, directly observed treatment, short course. The length of treatment: TB bacilli are killed during the first 8 weeks of treatment. Some survive longer and are then killed with continued treatment beyond 8 weeks. Length of treatment is a critical issue. If administered for too short a time, treatment failure and relapse can occur. So, the dosing schedule goes like this: the TB patients to receive daily treatment. 3 times weekly dosing is not currently recommended in either the intensive or in the continuation phase for all forms of TB and HIV TB. The case definitions of TB: initially, anybody with the symptoms of TB may be suspected as a presumptive TB and they will be introduced to appropriate investigations. From that, they may be labeled as a case of TB. This TB case may be a microbiologically confirmed TB case. Microbiologically means it can be a smear or culture or by a rapid molecular diagnostic tool. Otherwise, it could as well a clinically diagnosed TB case also. In either case, whether it is a microbiologically confirmed or clinically diagnosed TB case, they will undergo these 3 classifications. One is whether it is what is the anatomical site of the disease, second one is the history of previous treatment, and the third one is the existence of drug resistance among them. With regard to anatomical site of the disease gets classified as pulmonary TB or extrapulmonary TB. And as far as history of TB treatment is concerned, we have a new case or a previously treated case or a case which was diagnosed elsewhere and transferred in. In the previously treated group, we may have a fully completed treatment patient getting the disease again, who is called recurrent TB, or a patient who was started on treatment, stopped treatment in between and labeled as lost to follow up. That group also fits into this category. There may be a case of treatment after failure also, and rarely we have a category called others. And as far as drug resistance group is concerned, we may have INH mono resistance, or it can be INH with other drugs like polydrug resistance, or a multi-drug resistance where H and R are resistant, or it can be a pure rifampicin resistance and rarely extensive drug resistance, otherwise known as XTR. What are the case definitions in TB? As we discussed already, the patient could be a new patient. By definition, it means never taken treatment for TB or taken less than 1 month of anti-TB drugs. They are considered as a case of new patient. Then comes the question of previously treated patient. The patient received more than 1 month of anti-TB drugs in the past will be labeled as a case of previously treated. Then comes the question of drug sensitive TB. A patient whose CB-NAT, example GeneXpert or TrueNAT, is rifampicin sensitive or line probe assay is sensitive to INH and rifampicin is considered as a case of drug sensitive TB. What are the drug treatment regimens available for drug susceptible TB? In the new or previously treated, provided they are drug susceptible, they will be receiving an intensive phase of 2 months of 4 drugs, ethambutol, INH, rifampicin and pyrazinamide, followed by a continuation phase of 4 months INH, rifampicin and ethambutol, totaling 6 months. Treatment regimens for drug susceptible TB. National TB Elimination Program is recommending daily regimen for treatment of drug sensitive TB with fixed dose combinations in appropriate weight bands. The intensive phase is for 8 weeks, continuation phase is for 16 weeks and no extension of intensive phase is recommended. The treatment regimen for previously treated TB. Previously, we were using a category 2 regimen for previously treated TB, which is no longer existing. Previous treated patients also are initiated on 2 HREZ followed by 4 HRE as on par with the new TB patient, provided their current microbiological status is DSTB. DST at least for INH and rifampicin should be available. It can be by way of a molecular diagnostic tool like CBNAT or LPA, otherwise it should be by a liquid culture DST. Results should not be waited for starting treatment. This is most important. As soon as a person is identified as a microbiologically confirmed TB, we should try to initiate treatment as early as possible. If there is no resistance, treatment is continued. This is most important. We should always try to establish whether there is any presence of resistance among the previously treated. Isoniazid or rifampicin resistant, treatment is decided as per the PMDT guidelines. Treatment regimen for previously treated TB. The patients for whom an appropriate specimen is not available for DST, they are started on 2 HREZ followed by 4 HRE and followed up by clinically or radiologically or microbiologically for signs of non-response. Patient care and monitoring treatment outcome same as for new patients started on 2 HREZ followed by 4 HRE. The dosage of anti-TB drugs goes like this. It is based on the weight band. We have the first group which is 25 to 39 kg body weight. The second group has 40 to 54 kgs and the third group has 55 to 69 kg, and those who are weighing more than 70 kgs will come in a separate band. And this fixed dose combination, we have a combination of INH 75 mg, rifampicin 150 mg, pyrazinamide 400 mg and ethambutol 275 mg as a fixed dose combination for the IP. Suppose we have to use a pill for continuation phase where INH, rifampicin and ethambutol are administered as a fixed dose. The dose of INH remains as 75, rifampicin as 150 and ethambutol as 275. And as far as the number of pills is concerned, for the intensive phase, if the patient belongs to 25 to 39 kg, they will be receiving 2, and continuation phase HRE, FDC 2 tablets. See, for the person weighing 40 to 54 kgs, it will be 3 in the intensive phase and 3 in the continuation phase accordingly. Similarly, for the 55 to 69 kg weight band, it will be 4 tablets for the IP and 4 tablets for the CP according to the weight band. More than 70, they will be receiving 5 tablets both in the IP as well as CP. The only difference is CP will contain only 3 drugs, INH, rifampicin and ethambutol. The fixed dose combination tablets come like a strip in this, wherein which they have to collect the number of tablets per day and taken at a single point of time. What are the WHO recommendations on this? In patients with the drug susceptible pulmonary TB, the 6-month rifampicin phase 2 regimen will be 2 months of rifampicin, INH, ethambutol and pyrazinamide followed by 4 months INH, rifampicin and ethambutol is the treatment of choice. FDCs are better than separate drug formulations. Thrice weekly dosing is not recommended. Antiretroviral therapy should be given to all patients with HIV co-infection irrespective of the CD4 count, and a 6-month regimen is recommended for them as well. WHO recommendations continue. In patients who require retreatment, the 8-month regimen as category 2 is not recommended. Regimen should be decided after DST. Health education, counseling, treatment adherence measures to be provided. The drug dosages for adult TB goes like this. Earlier we were discussing about the weight bands. The dose that is decided is based on the body weight. INH is administered at the dose of 5 milligram per kilogram body weight at the maximum dose of 300 milligram per day. Rifampicin administered at the dose of 10 milligram per kilogram body weight with a maximum dose of 600 milligram per day. Pyrazinamide is recommended as 25 milligram per kilogram body weight with a range of 20 to 30, and ethambutol 15 milligram per kilogram body weight with a range of 12 to 18. There are certain treatment outcomes in the program. When we say cured, as per the definition, it is a pulmonary TB patient with bacteriologically confirmed TB at the beginning of treatment who completed treatment as recommended by the national policy with evidence of bacteriological response and no evidence of failure. When we say the treatment is completed, a patient who completed treatment as recommended by the national policy whose outcome does not meet the definition for cure or treatment failure is labeled as treatment completed. When we say treatment success, it is the sum of cured and treatment completed. Sustained treatment success is another terminology that is used in the program. An individual assessed at 6 months after successful TB treatment. That means it is a follow-up evaluation who is alive and free of TB. Treatment failed. By definition, it is a patient whose treatment regimen need to be terminated or permanently changed to a new regimen or a treatment strategy. Died. A patient who died of any reason before starting treatment or during the course of treatment. Lost to follow-up. A patient who did not start treatment or whose treatment was interrupted for 2 consecutive months or more will be labeled as a case of lost to follow-up. Not evaluated. A patient for whom no treatment outcome was assigned. This includes cases of transfer out to another treatment unit and those whose treatment outcome is unknown. However, it excludes those cases which are lost to follow-up. Then the treatment outcomes continue. There can be reasons for change, say for example, no clinical response and or no bacteriological response, adverse drug reactions, and there are evidence of additional drug resistance to medicines in the regimen may require a change of regimen. Bacteriological response, bacteriological conversion with no reversion is considered as bacteriological response. What is bacteriological conversion? At least 2 consecutive cultures or smears taken on different occasions at least 7 days apart should be negative to call it as a bacteriological conversion. Then there is a terminology called bacteriological reversion. 2 consecutive cultures or smears taken on different occasions at least 7 days apart are positive either after the bacteriological conversion will be labeled as a case of bacteriological reversion. Drug adverse events may happen. The pill burden may be one of the issues. Gastrointestinal symptoms may be there. Patient may experience arthralgia, hepatitis, itching, hypersensitivity, renal failure, thrombocytopenia or flu-like syndrome. So, what are the common drug related adverse events? All TB patients on treatment should be monitored for adverse drug reactions both clinically and with relevant investigations. Patients should be informed that the urine will be colored due to TB drugs and this should not be a cause for alarm. Most of the adverse effects are likely to be mild and can be managed with symptomatic drugs and with appropriate counseling. Serious adverse events should be appropriately managed. Treatment support program. Adherence to TB treatment is key to relapse-free cure. Counseling of patients and family members will ensure regular treatment. The patient's family, especially children, should be screened for TB. As far as the treatment support plan goes, there is an initial and frequent follow-up counseling of patient as well as their family members. The counseling is given for the nutritional support. The Government of India is supporting all the TB patients, both pulmonary and extra-pulmonary, with a national program called Nikshay Poshan Yojana, where all the diagnosed TB patients, whether they are pulmonary or extra-pulmonary, are given 500 rupees by direct benefit transfer to their bank account to augment their nutrition level during the course of anti-TB treatment. This is issued at the initiation of treatment, at the end of IP and at the end of completion of treatment for DSTB. And there should be a mechanism for retrieval of lost to follow patients or otherwise known as treatment interrupters. And there is screening for adverse events which is also done. Psychosocial support is given and comorbidity management is most important, particularly for conditions like diabetes, HIV and other conditions like smoking and alcoholism. Alternative DOT, the principle of patient centric approach, community and family centered DOT is preferred. Information communication technologies, modalities like frequent calls, SMS reminders, apps and IVRs etc. are the available tools to enhance this suggestion. Compensation to mitigate out of pocket expenses for the transport and wage loss is also possible, and incentives for treatment supporters. This is most important to facilitate treatment completion. Capacity building and engaging local community of the self-help groups and patient support groups also available in the program. And there is a need for treatment follow-up. It can be a monthly clinical follow-up or a laboratory follow-up to assess prognosis of disease and to manage comorbidities and toxicities. Sputum smear microscopy at the end of IP and treatment. If sputum smear is positive anytime during treatment, DST should be done as a presumptive DRTB case. Long-term follow-up happens at the end of 6th month, 12th month, 18th month and 24 months after the treatment completion. There is a systematic recording of TB patient details and follow-up in this treatment card which is available in the national program. As we have already pointed out, we will be finding out whether it is where is the site of the disease, whether it is a pulmonary or extrapulmonary, and what is the type of the patient, whether it is a new patient or the patient is a transfer in, or whether the patient is a lost to follow up and getting treatment again, or whether the patient is a recurrent or relapse, and whether it is a treatment after failure or rarely other category. Then we will be recording the details about the HIV status of the patient. As a policy, we should know the HIV status of the patient before initiating the anti-tuberculosis treatment. Evaluation of comorbidities. We will be talking about diabetes most importantly, and we will have to assess the diabetic status of the patient. Next, we will be recording the basic details of the patient confirmation, whether it is a microbiologically confirmed case, whether the smear is positive, what is the lab number, what is the test result, what is the next day ID, and all these results will be recorded appropriately. And we have to evaluate the family members to suggest preventive therapy for them. So, we have to screen those children below 6 years and those people who are more than 6 years in the family, and we have to screen them for possible TB among them. If they have disease, they will be treated simultaneously. If they do not have disease, they will be preferred for tuberculosis preventive therapy in the program. Serially, we are by measuring the weight of the patient and monitoring the dosage that what they are taking, and it is serially marked from the date of initiation of treatment every month, so that they complete the treatment according to the schedule that is offered. And if there are any missed doses, the retrieval action is taken, that is recorded separately. If they develop any adverse events, that is recorded meticulously, and measures taken to relieve the adverse drug reactions happen simultaneously. And we were talking about the post treatment follow up at the end of 6th month, 12th month, 18th month and 24 months. This is also recorded in appropriate columns by way of necessary investigations. And next day portion yojana we were talking is also documented, whether the patient is receiving at the end of 2nd month, at the initiation of treatment as well as at the end of treatment. What is the treatment outcome? We have talked about various outcomes like cured, completed, death, lost to follow, failure and so on. This is also recorded in the appropriate column, and the signature of the medical officer after recording all the details is a must with the date. If there are any other issue, that will be recorded in the remarks column. So, the key messages are: the goals of TB treatment are to cure the patient, prevent death and drug resistance, and to prevent transmission of infection in the community. Highly effective treatment regimens are available for drug susceptible TB. Treatment duration is for a minimum of 6 months with multiple drugs in the FDC as per the weight band. Under National TB Elimination Program, diagnosis and treatment are free of charge. Regular treatment adherence is crucial for the cure of the patient. Thank you.